Does it look like we have a quorum now, Shelley?
All right, please be advised all attendees this meeting is being recorded and will be publicly posted. Thank you. All set?
All right, thanks. So we'll call PMD to order today. Shelley, if you want to start us off with the roll call.
All right, roll call. Amber Rice. Erin O'Connor.
Here.
Brian Smith.
Present.
Chester Key. Franco Castamer. Garth Gamer. Heather Miller. Jason Johnson. Jason Payne.
Here.
Matt Shaw. Neil Gago. Paul Dabrowski. Shari Brand.
Here.
I count 7. We have quorum. Thank you.
All right, thank you, Shelley. Next, moving on to the chairman's report. There are 2 attachments, the attendance report, as well as the 2022 meeting schedule. Just remember that we do keep an eye on attendance, and if you miss more than 2 consecutive meetings, then we'll reach out and make sure you still want to be representative on the committee. And then for our next agenda item, we have the Bureau report. First up is Chief Garcia.
All right, good afternoon. I'll go ahead and share some brief updates before we pass on to Dr. Bradley. Some reminders that during our last statutory committee meetings, the Medical Direction Commission did approve an updated drug table for EMCPs practicing in hospital settings, as you all know. We also now have live on our website a pilot project approval process that will include MDC if anybody is interested in that process. We continue to monitor policies from national organizations, including NREMT, COAMS, and ACS. There are some waivers that are set to expire at the end of this year. We'll be keeping a close eye on those and also sharing information via GovDelivery with stakeholders regarding those national organization policies. We're also closely monitoring workforce needs. As you know, the surge line remains fully operational, and we are still working on the surge line staffing initiative, providing critical care nurses to hospitals throughout the state of Arizona. In January, we'll be conducting a survey to assess workforce needs and interests among EMCPs and organizations. Another project the Bureau continues to focus on is our rule updates for air and ground ambulance. The air ambulance rules packet has gone over to the governor's office seeking approval to move on to GERC. That is for Articles 7 and 8. We continue the informal process with a work group for the ground ambulance rules. We're currently looking at Articles 9 through 11 with a work group. Our next meeting will be mid-December, and we hope to continue to receive subject matter expert feedback on the ground ambulance rules to be able to post another draft in January for review. Please keep an eye out on our website for updates on the rule process, and let us know if you have any questions. I'll go ahead and quickly introduce some new Bureau staff, a couple of whom we have in the room today. We have Adam Rodriguez, our new EMS for Children coordinator, joining us today. We also have Marissa Salgado, a new base hospital program manager. TJ McKay, new training program manager. And Cody Curl, our EMS Workforce Initiatives coordinator. She is here in the room today, and we look forward to her working on a new workforce grant that we have received at the department. I will now pass to Dr. Bradley to talk about Naloxone Leave Behind.
All right, good afternoon, everyone. Just wanted to bring back to this committee the reminder that the Bureau does have the Naloxone Leave Behind program as an option for agencies to implement to help distribute naloxone within their communities. We added to our website a section that is specific to naloxone and it has resources which includes the training PowerPoint that agencies can use to train their personnel. It also has an educational pamphlet that can be given out with the naloxone, with the option to customize this to your jurisdiction with appropriate resources for your geographic area. The standing order is also there if you are a BLS only agency and you do not have medical direction. It outlines how you can obtain that from the Bureau. And we have a link to the Office of Injury Prevention where agencies can obtain free naloxone as part of the Leave Behind program. Just a reminder that we have definitely seen an uptick in opioid-related overdoses throughout COVID, and we want to do as much as we can to help decrease this within the community. If there's any questions, please feel free to reach out to me directly about that. Next up in the agenda is just a reminder about SHARE. Just for a little bit of context, the SHARE program has really made Arizona a leader in cardiac resuscitation nationally and internationally. When the program was first developed, agencies and hospitals were asked to submit their documentation to support their cardiac receiving and referral center status. That was well over a decade ago, and so we are really trying to circle back with all the facilities and make sure that they still have the appropriate documentation to sustain a cardiac receiving or referral center status. So Julia Vinton has sent out those requests starting over the summer, and we are working with hospitals to help maintain their current recognition status if applicable. One of the things that we have noted is that some items that were previously required, such as CPR education to the community, may be more difficult to implement with COVID. And so we're really trying to focus on the key elements of what's required to be a cardiac receiving center, especially to ensure best outcomes for patients in cardiac arrest. So that's just a little bit of background about why we are requesting those updates from hospitals. We are also working on potential automation of data. I know this has been somewhat difficult for some facilities. This will be probably a year-long project. We are going to be working with our data team here at ADHS to work with hospitals and the HIE to hopefully work on some type of data automation. Are there any questions about SHARE or naloxone leave behind? Excellent. I will hand it over to Adam then. Thank you.
Hello. We are keeping track of the NEDARCS data entry that recently closed in early November. And for the rest of the year, they are going through that list and cleaning it up and verifying our points of contact for our state EMS agencies. So that in January, when I'm given the green light, I can go ahead and push out the new 2022 EMSC survey and promote its presence across our Arizona EMS agencies. And that's all I got. That's all.
Right, I will start with the trauma report first. In 2020, we had 47 trauma centers reported to the trauma registry. Around almost 58,041 cases were reported, which were down from what got reported to trauma registry in 2019, showing the influence of COVID-19. And of those 58,000 cases, 1,442 deaths happened. That is 2.5% of total trauma incidents. We also did an analysis from the hospital discharge database in order to see the overall picture of injury in Arizona and what gets reported as a trauma in trauma registry. So what we found out is that there were almost 5,473,000 cases of injury got reported to hospital discharge database. Of those, like 58,000 got the trauma, which got reported to the ASTR. And the death reported in ASTR is 1,442, whereas in hospital discharge database, it is around 3,952 cases of deaths. A top 6 mechanisms of injury, again, fall was the number 1 mechanism of injury, and that's been the case in last many years, followed by the motor vehicle occupant. What we saw during 2020 is that the firearm got added as a top 6 mechanism of injury. It was never the case before. And some of the risk and protective factors, the seatbelt use, 67% of the MVT occupants were using seatbelt. And as risk factors, what we found out is that 25% of the trauma patients were either had a suspected or confirmed being under the influence of either drugs or alcohol. Those are some of the highlights of trauma report. And let's talk about the EMS report now. For the EMS report, we had around approximately 1 million records were reported to the ACPS. And of those 1 million records, 166 agencies that submitted the data to us. And when we take that 1 million records, put it into an average number incidents per day, it was 2,433 EMS incidents reported per day in Arizona. Most of them were ground incidents, 98% were ground, and then the 2% were air incidents. So 17,179 air transports occurred in last year. The interesting thing was that the 50% of the incidents were among patients aged greater than 55 years and 5% among the pediatric patients. If you read the county map, what we found out is that the rural area had a higher number of EMS incidents compared to the urban population. Some of the, when we talk about the median times, time intervals, 8 minutes was a response time, 11 minutes median was scene time, and 11 minutes median was a transport time. 18% of the EMS incidents were injury, 5% were substance abuse, 3.3% were psychiatric disorders, 2.6% seizures, and again 2.6% were opioid. These are some of the highlights from the EMS report. Both the reports are available on our website. If you have any questions, I can take right now. Thank you so much.
Thank you, Vatsal, very much. The last part of the Bureau report will be from Travis for the EMS Portal Revamp.
Good afternoon, everybody. Over the next year, the Bureau will be focusing heavily on IT improvements to the EMS portal to provide additional value to our stakeholders and internal staff. These improvements will consist of a complete modernization, a visual facelift to improve the look and feel of the portal, allow for the portal to be accessed and submit various applications from a smartphone, tablet, web browser. Also, we'll be developing a hub where the Bureau creates announcements, has educations, trainings, CEs, and wellness resources that'll be located within the portal. The portal will also contain a fully online CON application to eliminate the need to submit a paper application. We will also be developing a user-friendly online rates application and much more. The Bureau's vision for the EMS portal is to create a hub and a one-stop shop for all tasks, duties, applications, etc. that relate to the EMS and trauma world. Instead of accessing the portal only when needed, the portal will be a place where individuals will want to access often due to the value it provides in our everyday work and personal lives. During this time, we greatly appreciate feedback and involvement from our stakeholders to ensure a successful implementation that greatly benefits all parties and provides added value to our daily, monthly, and yearly functions. If you are interested in assisting our Bureau with this exciting project, please email me at travis.connors, CONNORS, @azdhs.gov. Thank you in advance for your support and participation as we continuously look to improve our services we provide to our stakeholders. Thank you very much.
Thank you, Travis. Moving on to our discussion and action items. The first one is to discuss and approve the minutes from the July 15th meeting. So do I have a motion to discuss this action item?
So moved, Brian.
Thanks, Brian. Does anyone have any amendments or changes that need to be made? not, we can take a motion to approve them.
So moved, Brian.
Thanks, Brian. Is there a second?
Second, Jason.
Thanks, Jason. All in favor of approving the July minutes, say aye.
Aye.
Any opposed? Okay, next item on the agenda, since that one passes, the next item will be to look at 2 new drug profiles for table 2 on the hazmat, propranolol. Well, there's a whole list here, but there is, actually, I'm not sure if any of these are new. I think there's just a couple of these that are new, correct, Gail? A couple of these are pre-existing. I think we just need to discuss the new ones.
I think we've got a few in here that we are looking to approve.
Oh, okay. I thought there were more. So in here, we have a sodium nitrate. These are all in your packet as well. Sodium thiosulfate. Ethylene blue. And dildo ejector. And, this is the combined methiodote. So if I can get a motion to discuss this action item.
So moved, Brian.
Seconded, Matt.
Is there any discussion on this action item? Any of the drug profiles listed?
Brian, I have a question on a couple of these. It's noted down at the bottom. There's a reference to a treatment guideline, and I didn't go look at a treatment guideline, but are these drugs actually listed in the treatment guideline yet?
That's a different action item.
Well, the two that we have today don't have anything to do with either one of those drugs, I don't think. One's for propranolol on hydrocarbon poisoning, and one is for that hemoglobin toxicity with methylene blue. So my question is, if those aren't, and I'm going to have a maybe a more general comment then on that topic, because maybe we can. We have kind of traditionally tried to keep STRs out of the treatment guidelines and leave that up to the specific individual medical directors to decide how those are going to work. And all of these drugs are off of table 2, which is an STR. So I guess my question is are we going to kind of break from what we've been doing in regards to STRs and start putting these things into the general treatment guidelines?
We do already have treatment guidelines for many of them. The ones that were missing were the hydrocarbon and the hemoglobinemia.
So those drugs from table 2 are mentioned in those other treatment guidelines right now, you're saying?
Mm-hmm.
Okay.
Any other comments or questions on any of these? If there's no discussion, we can take a motion.
Brian, so moved.
Second, Jason.
Jason?
Aye.
All in favor, say aye.
Aye.
And any opposed, say nay. Okay, that motion passes. The next agenda item up is going to be C, which is to discuss the 2 new TTTGs for hydrocarbon and for methemoglobinemia. So do I have a motion to discuss this?
Sharon, motion to discuss.
Sharon. Have a second?
Matt, second.
Thank you, Matt. Any specific question or discussion for either of these?
Hi, it's
Yeah.
Brian. So I do have a question, and maybe I missed this somewhere earlier on if we have some guidelines that references to table 2, but I'd like to know what a tox paramedic is. Because there's no such definition as that exists in any rule anywhere.
So Brian, I think this references back to the day when it was actually in rule, but our current TTTGs that we have multiple areas where tox paramedic only is specified. So
Well,
it was identified that these ones were missing. So to your point, you are correct. We don't have a definition anymore, but I think there is a general understanding that paramedics have some training kind of approved by their agency's medical director to be a tox medic. So it's not part of your general table 1.
Well, but I don't think I think we should not be using stuff that actually is, like in this case, it's almost identifying a level of training, and yet there's no definition for that. Maybe it would be more appropriate to put in there in big bold where there's tox medic STR/table 2. Because that's what it's really about.
We can certainly do that. And, we are going to be looking at updating the TTTGs next year. And so we can, when we look at doing that entire update for the packet, we can also clarify in the introduction where we've specified that in the past. But those had gone through the committee and haven't changed in the last few years since we first updated that.
Yeah, I mean, I'd be comfortable leaving it as is for now and then addressing them all at one time in the TTTG update.
It's Josh Gaither. I agree with that one.
Amber, just grammatically for accidental exposure, more is spelled wrong for more often.
Okay.
It means an E.
And I don't know if we want to change it here or not, but if EMTs can acquire an EKG, do we want to move that line where it says consider 12-lead EKG up to the EMT level with the STR in parentheses, or just leave it where it's at?
It's my understanding it's no longer an STR. It's just in the scope.
I need to pull up the scope to double check. I believe that the EMTs can acquire, they just cannot interpret. So I think that's the key delineating factor between the two.
Yeah, I looked at it fairly recently. So definitely something I think that we could address as a overhaul throughout update the TTGs. Shelley, can you scroll down just a tiny bit on this one? I just can't see the bottom of the box where it states that. Thanks. Yeah.
Hey, this is Erin O'Connor. I would just weigh in that on the methylene blue where it says do not administer in patients with known G6PD deficiency. That is certainly accurate. But I don't think SSRIs, SNRIs, and fentanyl would be a absolute contraindication to using methylene blue. Obviously, they worry about serotonergic or precipitating serotonergic findings, but A, fentanyl's ability to do that is likely very limited if actually true. And then B, if someone had life-threatening hemoglobinemia and was hypoxic or hypotensive and tachycardic, we would certainly not make those absolute contraindications by any means. So,
okay.
And I'm not sure about etc.
Okay.
That's pretty vague in there. Either put something, either be a little more specific, but etc. to me is not.
Okay. So I think the recommendation was just to remove all of those in general.
Yeah.
So.
Yeah, I would probably say do not administer in patients with known G6PD deficiency or active hemolysis. That would be a safe thing to say, period, and remove those other things.
Yeah, I didn't have active hemolysis written down on there only because it was, I don't know that they would ever know that.
Yeah, that's true. You can leave that off for sure. I think you're right.
Even the other one I think would be hard, but.
Hi, this is Shelley. For clarification, are there amendments for the hydrocarbon?
I
Okay.
didn't have any.
And then for clarification, are there amendments for methylglobin toxicity?
Yeah, so for this one, the recommendation is to basically remove the entire last line.
Remove the entire last box. Okay, thank you.
Yeah. And just end it with G6PD, period.
It's Shari. Can I just ask a quick question for the part on that talks about on the hydrocarbons? Cardiac dysrhythmia is less common, but can include fatal ventricular dysrhythmias such as PVCs. We've got that included with VT and torsades. Does that just give the impression like PVCs are included with the malignant dysrhythmias?
Shelley, maybe we just wrote that wrong in this one. Could we go scroll up to that one and double check? Probably just got written incorrect.
On the paper copy in front of me, am I in the right spot?
Up more to the hydrocarbon.
Because if anything, you can just move PVCs to cardiac dysrhythmias are less common, such as PVCs, but can include fatal dysrhythmias such as VTAC and torsades.
Yeah, that's fine. I was going to say the same thing. So Shelley, for you, cardiac dysrhythmias are less common, but can include PVCs or fatal dysrhythmias such as ventricular tachycardia and torsades.
Okay, so there's an edit to that third line after signs and symptoms.
Mm-hmm.
Shelley, I've got that written down. Yes.
Okay, if there are no other, oh, Shelley, there's a bullet that's kind of out of place under causative agents. I think it just needs to be dropped down a line.
All right, I'll get that fixed.
That's it, yeah. All right. If there are no other comments or discussion, I can take a motion to approve these.
Shari, motion to approve.
Is that Brian? I'm sorry, I didn't hear the second one.
I'll second it.
Thanks, Brian. All right, all in favor, say aye.
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 And any opposed or abstentions? Okay. That motion passes. And Shelley, could you pull up the agenda one more time? Mine crashed on my computer. There it is. And then the next action item will be to look at table 5.2 and discuss some potential edits to table 2 here. So do I have a motion to discuss this?
So moved, Matt. Second, Jason.
Jason. So this was the list that was reviewed and has some recommended removals from it. So we recommended removing, kind of among other things, the activated charcoal, just as it is not currently in our TTTGs, and then removing the cyanokit and the duodote and the Atrovent, as they are already listed in the general drug table. So most of these are.
I have a question then, because you're noting that those are listed in the general tables, but hydroxycobalamin is also, and sodium chloride and glucagon, which was actually going to be a question of mine. Is it necessary to have these in the separate table when they're already in the general drug box?
And that was kind of my thought too, just to kind of make it clear. Could you maybe change it at the top and say additional agents eligible for administration, and then just have it specifically to these additional drugs and not to include the ones that are already in their standard drug box?
I don't know that the rule writer will let us change the title of these tables. we had voted one of those with table 3, and then we had to do a lot of maneuvering. So I think that, correct me if I'm wrong, Rachel, but I think the drug table name and descriptor, we don't have the option to update. But certainly I think the point is a good one, which is any item that we have on table 1 is already approved for any paramedic in the state. So do we really limit this drug box to any medication that is not part of table 1?
That's what I would think, is Jason, that, yeah, just keep it as simple as we can.
Yeah, this is Matt. I would agree. It seems unnecessary to write them down twice.
And this is not a time-sensitive one, so if we need to circle back on this and just do a better cross-reference, we can do that as well.
Can we just go ahead and, I mean, I don't think it'd take too long, just go through the ones that are already in the drug box? I mean, is everyone kind of in agreement of simplifying it, kind of like Brian was saying?
Yeah, I think that's completely fine. I think that the discussion was a list that would include things that were sort of generally in the tox box, but we had also discussed eliminating ones that were redundant in the general drug table. So I think that would mean that albuterol atropine.
Right, and like the glucagon, the Valium, the dextrose. I mean, could we have to do a separate motion to like strike those additional ones that are already on there, or can we just agree to remove the ones that are already in their standard drug box?
I think we could take a motion. Sorry, were you talking, Gail? Oh, no, it's my echo. I think we can take a motion to remove any items from this table that were listed already on the general drug table.
Right, and that would be my motion.
Okay. Do I have a second to this?
So, Dr. Bradley, I have a question about that topic of the title. When we moved these out of rule and it went to MDC and then was signed by the director, Table 1 got renamed because that used to be agents authorized for administration and so on, and now it says EMCT drug box. So we wouldn't be able to add additional drug or additional agents then, because they did change the name of Table 1 when we made that move.
I think, Brian, we'll have to circle back to the rule writers. I know they have had some issues with just making sure that the drug table names that we are consistent. So we'll have to take that back to the rule writers to ensure then.
Okay.
So maybe we could just kind of approve it with the changes that we discussed, with the recommendation that we change the title of the table if possible.
Okay. So the motion currently on the table. Noreen, before I do that, do you have a question, Noreen?
Yeah, I just wanted to weigh in on the conversation about the names of the tables. It's not necessarily that the name can't be changed, but the names of the tables appear in other rules throughout our rule book. So logistically, that would be problematic because we would have to tease out everywhere those names appear and then change them, and those rules may not be open for changes. That's just from a regulatory perspective.
Okay.
That's all I have.
Thank you, Noreen. Okay, so the motion we have on the table is sort of in addition to what's seen here in the table, the changes, any additional drugs that are already listed in the general drug box table would be removed from this list as well, leaving the additional items. So that's the motion that's currently on the table. Do I have a second to that motion?
Second, Brian.
Thank you, Brian. All in favor, say aye.
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 And then are there any opposed or any abstentions? All right, thank you. And so we could follow up on the name change or potential name change later, I think. The next on the agenda is going to be any agenda items that anyone would like considered for our next meeting. If there are any, please send those to Shelley.
Okay. Yeah, this is Jason. The only other one that was brought up to me is now they have intranasal glucagon. If we could add intranasal to the other administrations of currently for glucagon. So maybe that's something we might be able to discuss at the next meeting.
Intranasal glucagon?
Intranasal, yeah.
Okay.
And it's only because my son's a diabetic and he uses intranasal if we need it, and that became a discussion with our EMS agencies.
Okay, all right. Thank you very much.
Hi, it's Brian. I just have one comment. It just dawned on me that the name of that table is in table 5.1, the scope of practice. So I don't know that we need to really pursue that.
Okay. Thank you, Brian. If there are no other immediate agenda items to be added, we can make our call to the public. Hearing none, I'll just plug a couple of upcoming events. There's the AIMS Second Annual Fall Forum and the Annual Pediatric Symposium in Flagstaff. Those are in December and February. And you can also see any other upcoming events on the Bureau's News and Conferences page. Our next meeting is going to be March 17th, 2022 at noon. And if there's nothing else, I'll take a motion to adjourn.
So moved, Brian.
Great. Thank you all. We'll see you guys all next time.
Thank you.
Thanks.
Thank you.
Thank you, Shelley, as always.